All right, welcome to the last chapter in Unit 1. This is around disorders of the male reproductive system. Lectured on this past class. In case you missed it, though, it's here. So, quick A and P review. Not going to go too far in this. Assume you know a lot of this stuff, hopefully, but male and female reproductive anatomy slightly different, right? The biggest thing for males that causes some problems or thing to note is that males share the same tract for urinary flow. So the urethra runs the length of the penis and out. That's the same for their reproductive tract. So their reproductive tract starts in the testicles and the testes here. Sperm gets made, matures in the epididymis here, or epididymis, whatever you want to call it. Matures here and then makes its way up this tube called the vas deferens, and sperm and semen, well, semen as it's called because it's sperm plus some secretions. It's going to make its way all through here. It's going to get some secretions added to it here, secretions added to it here. And then this gland here is the prostate gland. And you can see that the vas deferens meets with the urethra coming from the bladder inside the prostate gland and then meets up with the urethra and runs out to the body. So this is where a lot of problems come in for men. As we get older, we'll talk about, or as men get older, to talk about the prostate enlarging, and we'll talk more about that. But that's kind of the basic anatomy that you would need to know about men. And then also just anatomy wise, this is why men are less prone to UTIs. Women are more prone just because the testicular sac, the scrotum is in the way of stool, and the bacteria that's in stool being too close proximity to the urethra, and the urethra is much longer in males, and so the likelihood of bacteria making its way up is less likely. It doesn't mean men don't get UTIs, but just the anatomy is different, right? So things to keep in mind when you're talking about health history, especially sexual history with men or women, you have to promote, a safe environment for them and express understanding that you're here to help the patient. This is a conversation that makes a lot of people uncomfortable, but it's a conversation that needs to be had in the medical world. And then gerontological considerations for older commonly BPH, benign prostate hyperplasia, very common. We'll talk about that more. So prostate enlargement, secretion of the gland of the substance the prostate secretes along with the other glands is minimal. So sexual response is also decreased, and there's just higher overall risk for maintaining that. So some things to note. I'm going through these pretty fast. One thing they talk about this with female health too, and breast self exams. For males, there's a self testicular exam or self testicle exam. This is supposed to be performed once a month, um, in a warm shower, and you're just looking for lumps or nodules or things that seem out of place for testicles. And this is looking for testicular cancer, which we'll talk more about later in this chapter. But testicular cancer is fairly more common among the young people, age 15 to 35-year-old males, and so it's more common to definitely be checking this for those high school to college age to young adult into 30s-year-old males to be checking their testicles once a month. So, what's the primary purpose of self exams in male? It's three. I mean, that one's fairly obvious. It's to look for any abnormalities in the testicles, preferably. Um, again, most commonly could be testicular cancer, but could things like testicular torsion or just benign masses, stuff like that. So all worth checking out for that reason. So the answer is the third one here. So we'll move on to talk about prostate. Prostate exams can be done by a physician or a mid-level, I believe, certain cases PA, but usually by a physician, and they can do a physical digital exam with a finger without um, having to do necessarily imaging. Like digitally, a finger can be inserted into the rectum. They can feel the presence of the prostate. If it's enlarged, it'll be pushing against the rectal wall there. And so you can see the difference. So again, that prostate gland is where the vas deferens from the testicles carrying the sexual reproductive semen, sperm, and the mixture of secretions meets with the urethra, which is going to carry urine, sometimes when we're needing to pee. And so they meet together here, right? But you can see when there's an enlarged prostate, I mean, look at the difference in size. The pressure point becomes here and it starts pushing on the urethra and all this and going to limit sexual function, going to limit urinary function. That's the biggest symptom with prostate issues. And prostate enlargement does enlarge slowly as all men get older, just varying degrees on how bad it is. Some labs and things we'll talk about PSA a little bit more. I'll mention this again when we talk about the prostate, but PSA is prostate specific antigen. And this looks for, again, significantly higher this antigen will be if the prostate is super enlarged or if there's prostate cancer or urinary retention, that sort of stuff. And a lot of things for male sexual reproduction, ultrasounds can find a lot of those things. So non-cancerous enlargement of the prostate, I already kind of talked about this, but this is BPH or benign prostatic hyperplasia. So fairly obvious. We'll talk more about it. What tests is used to evaluate the prostate and male urinary health? This is PSA level. PSA level. So first, the big point to talk about, we'll talk more about PSA and prostate BPH, but first big thing is talk about is erectile dysfunction. Sometimes you're going to hear this shorthand as ED for erectile dysfunction. The definition really is just inability to develop or maintain full erection. It's not necessarily always psychological reasons or physical. It could be a combination of the two, but some of the psychological is really distress and depression or general anxiety about sexual intercourse, so kind of performance. Organic or biological causes are always going to be vascular because how the penis works for erection is it fills with blood. There's large tubes that fill with blood in the penis, and that's what gives it the shape of an erection during sexual stimulus and arousal period. And so blood flow is a big important thing. So if someone has issues with blood flow, such as atherosclerosis, hypertension with blood vessel damage, diabetes, these can all limit the effectiveness of erections and the blood flow to the penis to correlate an erection. And so that's the kind of pathophysiology behind it. Sometimes too, if someone's suffering from erectile dysfunction, you might have heard this word thrown around. Sometimes this gets thrown around. It's a scientific word, but it's impotence. You may have heard that word used somewhere, but not really sure what it meant. It means erectile dysfunction means inability to maintain an erection. Some words, again, some more words down here that are nice to know, but not need to know. They need to know is just what is ED. It is inability to develop or maintain a full erection. And it can be physical or biological in nature with vascular issues, or it could be psychological or the combination of the two. Some of the words that are nice to know, nocturnal penile tumescence, NPT for short. Sometimes that gets thrown around. For lack of a better term, this is what people would, pop culture, whatever we'll call morning wood, a man waking up with an erection or having an erection during night, nocturnal penile tumescence. That's where that comes from. And that's actually a healthy indicator of male reproductive function. So if you ever have talking sexual characteristics, especially with like a young adult male teenager going through puberty, that this is a healthy sexual response. There's not much they're going to be able to do to control this, and it's okay. It's normal. Some medication side effects can also cause erectile dysfunction, so that's important to know. So medications that treat erectile dysfunction, the big category is these guys, PDE5 inhibitors. PDE5 stands for phosphodiesterase. So phosphodiesterase type 5 inhibitors. Basically, phosphodiesterase is involved in smooth muscle contraction. And so what PDE5s do is they're going to allow basically a smooth muscle relaxation. Written right here. They're going to allow smooth muscle relaxation. And you can have known some of these brands probably. They all end in the same suffix, afil. But Cialis, Levitra, Viagra, the blue pill, I think it's shaped like that. I don't know, something like that. So those are PDE5 inhibitors, and they're trying to inhibit that PDE5, that enzyme, and allow smooth muscle to relax and dilate That's the other word I was looking for. Dilate. The smooth muscles dilate, and that allows the blood vessels to dilate, filling with more blood. And so this helps with erectile dysfunction by kind of allowing the big, large blood vessels throughout the penis to fill with blood, and that's muscle to relax so that sexual arousal can happen without impeded by, again, overcoming the stress and mental power, and or the physical power of bad blood flow and stuff. So the thing to note about PDA5s, again, this isn't pharmacology, but we do want to note some stuff. The thing about PDE5s and meds that treat erectile dysfunction is that they're contraindicated in some cases. The biggest thing is obviously they're a lot about blood flow because they're technically at baseline, these meds are technically alpha blockers. They block the enzymes that help control blood pressure in the sense they're basically, in a sense, they're not technically categorically vasodilators, but they kind of are. Vasodilators, I mean, they dilate the blood vessels by default by their mechanism of action. And so what's that going to cause? Hypotension. So the biggest contraindication or adverse effect of PDA5s is hypotension because it's going to drop blood pressure 10 to 5 millimeters of mercury in either way. And if you pair that with someone that's already taking blood pressure medicine, well, then you can see where that could become a problem, right? So keep that in mind. If you hear PDO5s, the biggest contraindication, the biggest concern is hypotension. And there's other meds and other methodologies for treating erectile dysfunction. There's other meds that fit different categories than PDE5s. I think HIMS is one that's out there. There's vacuum erection assisted devices. There are some injections. It's a little crazy. Penile implants is an odd one. These are not the PDA5s, and what I just talked about with those is the need to know. These are just nice to know. You don't see a lot of these implants really anymore. I've seen a few, and I've seen them where they also fail, and it keeps the penis erect, and that can cause tissue damage, and it's uncomfortable for the patient and everybody around. And so it's an odd one. It's a weird fluid reservoir that pumps up, and it's an odd thing, but it has been known to work. And so I don't know how frequent this happens, but I know I've seen it a few times in my career. And this just kind of gives you a list of how they would go these couple next slides. Just talk about what they would go through to try and help with erectile dysfunction. Usually start with oral meds and working their way through. And there's an algorithm to that about that sort of stuff. And of course, health and sexual history are a huge important part of this review. And so PDE5 inhibitors is the right term here. This is the class that's commonly used to treat it. So BPH, or benign prostatic hyperplasia. This is another one of the big need to knows from this chapter. So far, really the big need to knows have been, what is a testicular self-exam for? How is it performed? What are PDE5s for? What's a big contraindication with those? How do they work? And now we're talking about BPH. So BPH, benign prostatic hyperplasia. So there's some words here that make sense. Hyperplasia, if you think back to pathophysiology, and we talked about cellular changes, hyperplasia just means more cells, more numerous cells. Hypertrophy means the cells enlarge. And so BPH means the prostate gland enlarges. So hypertrophies and the cells become more numerous, and that's hyperplasia. So BPH. And this is common for older men. As men get older, the prostate tends to enlarge anyway. Has something to do, the patho behind it, this is definitely a rabbit trail, but if you want to know more of the pathophysiology behind it in detail, it's basically related to a derivative of the testosterone hormone, like you would call it a metabolite. It's called DHT, dihydrotestosterone. It seems that at older age, that derivative of testosterone is higher, and that causes in growth of the prostate and causes potential for prostate cancer and BPH. And so what are the manifestations? I say that's the big kind of hone in point. What are we going to see in this patient? So most of the manifestations become urinary because, right, this prostate is now blocking the junction where the vas deferens meets the urethra. And so a lot of times it blocks urine flow. So basically a weak urinary stream, dysuria, possibly, what they would call incomplete bladder emptying, and potential for more frequent UTIs, maybe even incontinence. Again, incomplete emptying, they'd also call like they void, but they don't fully empty. So post void residual urine, you would see that on a bladder scanner, urine that was left over. You can treat this. There's a way to decrease DHT. There's PDE5 inhibitors. There's also smooth muscle, uh, um, smooth muscle contractors that will help kind of push, basically, and push some of the tissue out of the way. Those are known as Flomax, the name brands, and like Cardura. These are name brands. Flomax is tamsulosin. So there's some meds that help treat it. Also, potentially, if we're talking severe BPH, again, BPH is benign by itself. It's not a neoplasm in the sense of it's a new growth that is unexpected with age. It's not a neoplasm or malignancy. It's benign growth. But they have other methodologies to treating it besides medications. They can do a microwave therapy, like thermotherapy, where they heat up inside and try to burn away some of the tissue. But the main gold standard that gets talked about a lot for this, at least at this time, is TURPs, transurethral resection of the prostate. TURPs, they go in with a scope, they try to heat up or they try to pull out and dissect, take away some of the tissue surrounding the urethra of the prostate to remove some of this tissue to let the urethra have its space to, flow like it should. And they pull that back out through the urethra. So the biggest problem for this patient, if you can probably guess, is usually going to be bleeding and blood clots. So for a TERT patient, the biggest thing that they have after is hematuria for sure, because of all the things we just did to the inside of their lining of their urethra and all that area. Hematuria, and blood clots in the urine is very, very common. And so a lot of times with a TERP, they'll have to do CBI, continuous bladder irrigation. I did a terrible circle there. CBI, continuous bladder irrigation. And the thing with continuous bladder irrigation is really, I'll show you a picture of it, but it's interesting. CBI is really just a useful tool where it's a traditional Foley bag, that has an extra catheter lumen in it, where it has bags of fluid attached that flow into the bladder, keep everything moving, and then flow out. And this keeps urine moving. There's never a moment with CBI that this flow through into the bladder and back out is static. You don't want that, because as soon as it's static, a blood clot could wedge itself in the way of the urine flow and cause an obstruction and cause even kidney damage and acute kidney injury. And it can be all kinds of problems. So the biggest thing for a patient is starting out is keeping this fluid running. You never ever want the fluid of a continuous bladder irrigation to run out. Prostate cancer, I don't think there's too much to be said. Again, risk factors have to do with the DTH of hyperprostate, usually greater than 50 years old, African American, genetic history, increased fat and diet. Often it's fairly asymptomatic until it metastases. So sometimes prostate cancer could be troublesome. They can, if they need to, if whatever the problem is, if it's BPH or prostate cancer and they need to remove the entire prostate, they can. They're 100% going to likely have continuous bladder irrigation after this procedure. It could be done as a TURP, transurethral resuscitation, and they can take the whole thing, or maybe an open surgery. So a proctectomy or a TURP. Again, the CBI and what it's used for is to treat all this blood flow that's going to happen from tissue damage and to keep clots from blocking the urethra and the blood flow or the urine flow. So the management of CBI is the point. You can see like a normal catheter, right? It's just this tube coming out from the bladder and like a port like this. But you can see with continuous bladder irrigation, it's a three-way lumen where you have your urine going out, but then you have your fluid integrating into the bladder, helping keep it moving, and then coming back out in the form of urine. So when they first come out, you kind of manage CBI by color. So when they first come out, it's going to look like this. It's going to be very like dark red or pale red, pink. And slowly over time, it'll get more amber, and then it'll start clearing. And then eventually, once it's clearing, the clots and some stuff is healed enough where it's not dumping a bunch of clots or blood, and you'll be able to take them off irrigation. But the biggest thing again is you never want to let these bags run out for continuous bladder irrigation. Again, that's what they look like. They're these giant, like 3 liter, 3,000 milliliter bags. Each of these is about 3 liters. And they just run into a tube that goes in again to the bladder and then back out through the Foley catheter down here. And the biggest thing is, again, just don't want to let the fluid run out. You want to keep a continuous flow going until the urine stays a certain color. A lot of times the orders will say, keep continuous bladder irrigation going and titrate till urine is amber colored or till the urine is lacking blood clots, that sort of stuff. There'll be orders like that. So, going to bounce around for a few conditions. One condition that could definitely show up in your test that you need to know is phimosis here. Phimosis is fairly straightforward, but it's basically phimosis is a name for when the foreskin of the penis cannot retract. So, this would be only possible or only happening in patients that are not circumcised. Patients that are not circumcised have a foreskin that can sometimes go over top of the tip of the penis. And if that gets wedged over top and can't recede, there could be swelling, inflammation, infection, and not allow that foreskin to recede. And that's going to cause even more irritation, more inflammation, and could cause a deadly infection. And so they can treat with a steroid cream and try to get it to swelling to go down, get the foreskin to retract. But if they cannot, they would have to do a circumcision, in an older adult patient if they needed to. The reason this might happen usually is related to poor hygiene and stuff like that. People are able to keep themselves clean. Foreskin has to be cleaned and pulled back, and the tip of the penis needs to be clean. So it sounds gross, but if you have a patient that can't take care of themselves at all and they're not circumcised, to be a diligent, whatever patient care tech, be a diligent nurse that's giving a bed bath on a patient like this, you'd have to pull the foreskin back, make sure everything's clean. The last thing you want is infection, irritation, or phimosis to develop, right? So that's what phimosis is. There's some other conditions I'm going to pop over. Priapism, if you want to put a word to it, it doesn't necessarily show up on your test. I'm giving you that freebie here, but priapism is the condition name for when an erection lasts longer than 4 hours. You've probably heard this on the commercials for some of the erectile dysfunction meds, right? The PDE5 inhibitors like Cialis or Viagra, that it's blood flow gets shunted here during sexual arousal into the penis to fill it with blood. And that blood flow is other places when a man is not erect. And so that blood flow being there longer than 4 hours can cause blood shifting, can cause dehydration and hypovolemia and weird things. And also can cause damage to the tissue because these chambers are filled with blood here, these big, large chambers inside the penis called they're called the corpora cavernosa, I never say this one, cavernosa, corpora cavernosa. You don't have to know that. I can never say that one. But those are the chambers, the blood, and it's just not good for it over time. And so they need to seek medical attention. They may have to do some dissection, some removal of tissue to allow the blood to drain, and then kind of figure out what the overarching cause was. But priapism is not something that shows up in a test. Orchitis and epididymitis, not necessarily as well, but these are different types of infection you found in the testicles themselves. One thing that for sure will show up on your test that is testicular torsion. Testicular torsion is an emergency situation, surgical emergency. It is a situation, right? So, so what testicular torsion is what they call the spermatic cord here. This piece of tissue that's filled with blood vessels and its capillary system, along with the vas deferens and connective tissue, comes down to the testicles inside the scrotum. Each testicle has its own spermatic cord. Well, if something happens and this gets twisted upon itself like this, that kind of blocks and cuts off the blood flow and the circulation. And then the risk of losing the testicle is very high if this is not treated or dealt with immediately. So symptom-wise manifestations is sudden pain, usually unilateral to one testicle to the other, It's going to be nausea and lightheadedness going on with this. And then obviously the scrotum is going to start to swell. And there's another good picture here that kind of gives it all. So again, the patho behind this is the testicle rotates, spinning the spermatic cord, and this blocks blood flow and can lead to tissue necrosis. Again, sudden severe pain on affected side, swelling and redness. What causes this? So most of the time it ends up being a male that has an unknown testicle defect where the attachment of the testicle to the scrotum didn't really happen at birth. And it's mostly unknown because if they never suffer testicular torsion, you probably no male would probably ever know they had this. It happens more. There's not that many numbers on it, but that seems to be the most common cause why it might happen. Some minor trauma or vigorous physical trauma. The other stories I've heard with this is like, people doing sports, skateboarding, that sort of stuff. And having a severe injury, landing on their groin and hitting their testicles, this could cause it. A kid jumps on their parent, on their father, lands on their testicle. This could happen, that sort of stuff. It's not, again, it's more likely going to happen if someone has this birth defect they just don't know about, where the testicle's not fully attached to the scrotum. And then it could happen. But again, at the end of the day, this is an emergency situation that they recommend treatment, surgical treatment to fix. And you can't just physically untwist this yourself. That'd be kind of crazy. If you could, that would hurt. You'd have to have surgery to open the scrotum and untwist the spermatic cord to make sure blood flow is intact. And within 6 hours is the goal. 6 to 12 hours, you're going to start seeing tissue necrosis and cell death and could lose the testicle. So 6 hours, surgical intervention is what recommended. Gross image incoming, 3, 2, 1. So this is what testicular torsion kind of looks like as it gets worse and worse until the tissue starts to just turn dark purple, loses blood flow, and then the cells are dead and the testicles are not salvageable. This is kind of just, again, showing you what happens. This is a good image for it. Goofy cartoon, but it talks about the most important thing with testicular torsion is time. And you can see this on an ultrasound. That's how if someone in the ER had the complaints of nausea and feeling lightheaded and groin pain that was unilateral, and they had a recent traumatic event too, then they would go ahead and go to the ultrasound and think testicular torsion. So the other thing too is that testicular cancer. So that is, again, I talked about, that's the breast self exams. That's for young men 15 to 35 years old, typically is the range that this is the most common in. It's a really good prognosis. Survival rate is like 95%. So good prognosis. Again, risk factors, family history of cancer. This is more common in Caucasian males. That's what the self exam is for. And again, much more common in that younger population. So it's good to keep in mind for that. So, which of the following interventions is essential when managing a patient with continuous bladder irrigation? I think you can kind of figure out what this one was. It's urine output. We're looking at intake and output. That's what we're figuring on. It's what we're worried about the most with this patient. What about as a recommended treatment for testicular torsion? If you said surgical intervention, you were paying attention, right? And then what's a potential uncomplicated or complication of untreated priapism, which again is not a big focus for your test, but definitely phimosis is. But what's a potential complication? It's blood flow to the penis, and then tissue necrosis and pressure on surrounding tissues. It can be all bad. So that summarizes chapter 53, the male reproductive system and male reproductive system disorders. You have any questions, of course, let me know. Thank you guys for watching. Thank you guys for listening. Have a great day.